This is a live recording from Radiopedia.org's 2015 Emergency Radiology course in Melbourne, Australia, featuring Dr. Andrew Dixon and Dr. Frank Gaylard. For more information about Radiopedia courses, visit radiopedia.org/courses.
Welcome back after lunch. Hopefully a bit of glucose will help you, and we're going to take this through the next 2 hours with brain, head and neck and spine. Before we start, I just wanted to say thank you to all of you turning up again. The way that we can make all of this possible and to share this course with everyone in the world is through you guys supporting us. And also thank you to all the people who contributed cases to the site over the years. We're approaching 20,000 cases that are all available for free for you guys to look at and teach from. And as you've seen with Andrew this morning, many of the cases we've been able to show are amazing and contributed by people from all parts of the world. So this collective ability to share information and teach each other is something that's at the very heart of what Radiopedia is all about. And this is the structure of the next 2 hours. Some of this is not that you're expected to know how to diagnose it on your own. There's a lot of the skill of non-radiologists using radiology is knowing when you need to ask a radiologist. But the areas that we'll be focusing on, which are really the meat and potatoes of emergency neuroimaging, are hemorrhage and ischemic stroke. And I'm going to really try and give you a foundation to understand the pathology of these so that you can interpret these extremely quickly and accurately. Lumps and bumps or tumours is really just a smorgasbord of odds and ends. Head and neck is similarly filled with a whole bunch of different conditions, and we'll pick out a few that are really important or that highlight some important teaching points. And then with spine, we have some trauma, and with lumbar, we just have a few common things. A lot of the lumbar and thoracic fractures are really only seen in the higher speed or more energy trauma, which Andrew covers in the trauma course. So we're not really going to spend time on this. So let's start with intracranial hemorrhage. We traditionally divide it into where it is within the brain. Either it's intraparenchymal or extraaxial. And with the intraparenchymal component, we traditionally divide it into primary, in other words, it just happens, and secondary, or there's another lesion underlying it. This clearly is a bit of an artificial distinction in that primary hemorrhages also have underlying causes, which we know about. So they're all kind of secondary to something. An extraaxial is divided according to which compartment in the brain it occurs, and we're going to work our way from superficial to deep through extradural, subdural, subarachnoid, and then intraventricular, which no one can seem to agree on whether it's intraaxial or extraaxial, or whether it's a compartment on its own. But it's really continuous with subarachnoid, so we're only going to touch upon it where it's involved. So let's start first off with a poll. If you've lost your browser place, that's the link to it. It is case sensitive, so you need capital E and capital R. So which of these 4 hemorrhages is likely to be due to poorly contained, controlled hypertension? And you can pick as many as you like. Go nuts. Let's have a look. That is the wrong question. But that's ABCs will still work, so that's all right. Don't read the question, just put A, B, C, or D. That is entirely Dixon's fault. So the correct answers are A, B, and C. So let's have a look at these. The typical locations for hypertensive hemorrhage is cerebellar hemisphere, basal ganglia, which is the most common, and pontine. This example is of a lobar peripheral hemorrhage, which is not typically associated with hypertension. So let's have a look at a typical basal ganglia hemorrhage. We've all seen these. Patients present acutely with usually quite profound neurological deficit, often hemiparesis, and we can see a hemorrhage centred deep within the brain near the basal ganglia. That's the head of caudate, and it's ruptured into the ventricle. Here's clot in the ventricle, and here's some layering blood. You'll also note that the ventricles are distended because of the clot obstructing outflow. So we have hydrocephalus. They are very much located in the central parts of the brain. They can sometimes track more superficially, but usually they contained centrally and track into the ventricular system. CTA is not something that you'd usually do. Most of the time you'd say if this patient has a known history of poorly controlled hypertension and they have a basal ganglia hemorrhage and they're elderly, you don't need to look for an underlying cause. If you're at a hospital though that is trialling or using procoagulant therapy in these patients, you may be doing a CT angiogram to look for this, which is the spot sign. And this shows just acute extravasation of contrast into the clot. So when you're scanning these patients, it's important to remember that this is a snapshot in time. They're not static. You don't know that their hematoma hasn't just started bleeding and may continue to enlarge. If you see acute extravasation anywhere in the body, you can guess that it's going to get bigger. And so it's a way of selecting patients for closer monitoring or for therapy if that's available. And this is what it looked like the next day. You can see that the hematoma has increased. You'll also see that it's very hyperdense because of the contrast that's now mixed into the blood. In contrast to a basal ganglia hemorrhage, here we have a lobar hemorrhage. These are located peripherally within the brain. Typically the bleeding occurs near the grey-white matter junction or in the white matter, and then goes all the way to the surface of the brain. It can be associated with subarachnoid or subdural blood in some cases. And it can also track down inferiorly through the white matter tracts. Remember, white matter is predominantly axons that can just act as a guide for fluid or blood or edema or tumour cells. And here it has ruptured into the ventricles. But this peripheral component is characteristic of a lobar hemorrhage. And again, this you need to think of, is this in the right age group? Elderly patients, and we're talking 70 and above, have a high incidence of cerebral amyloid angiopathy, which is correlated with Alzheimer's as well. And these are the patients that develop lobar hemorrhages. So in that situation, if it's an 80-year-old and they have a history of dementia especially, and they have this kind of hematoma, you don't really need to go looking for an underlying cause other than a spontaneous primary hemorrhage. And this slide, it's a little bit busy, but it really brings home a couple of important features. One, that the distribution of hypertension, these are all MR images, these are susceptibility weighted, which means small amounts of blood show up as big black dots. Hypertension doesn't really affect the peripheral brain. It's clustered in the basal ganglia, small microhemorrhages, and pons and cerebellum. And that's where you get your macrohemorrhages. Similarly, cerebral amyloid angiopathy, microhemorrhages occur in the same distribution as you see in larger hemorrhages, located peripherally, grey-white matter junction, often with superimposed chronic small vessel ischemic change. Nothing much in the basal ganglia, but a lot in the posterior fossa. This is a rare condition, only put in for illustration purposes. It's multiple cavernoma syndrome, which is an autosomal dominant, not very imaginatively named condition, where you have lots of cavernous hemangiomas. And they're randomly distributed. And just like all other vascular lesions in the brain, they are essentially randomly distributed, so they won't follow a particular pattern. So when should you be worried that there's an underlying cause? Well, the first thing is patient demographics. A young patient with a hemorrhage who hasn't been hit on the head has an underlying lesion. You have to find it, and you'll usually need to go to MR. But we're not going to cover a lot of MR in this course because one, there's not the time, and two, you usually don't get exposed to that in the emergency setting. So CT and CTA is really the core of what you are going to be using. And one of the tricks is to look for an area of blood that is not as dense as the rest. As blood extravasates, it begins to clot. As it clots, it retracts and expels serum, which is absorbed by the brain and taken away. And so you're left with a hyperdense blood clot. Where you have non-clotted blood, wherever it is, whether it's still contained within a lesion or has just bled, it will be lower attenuation. And so here we can see this very well circumscribed, rounded structure within a clot. That is not what a normal hemorrhage looks like. You can get hyperacute hemorrhages that appear swirling because the blood hasn't clotted yet, but this very rounded appearance should make you think that there's a rounded lump underneath it. CTA is your friend. We despise it. It takes a long time to read. It's boring. It's like reading a Melways and trying to figure out which branch is missing. But it's a very powerful test. And here we can see that this non-clotted component of blood is a large ICA aneurysm. And they went on to have a carotid injection during a digital subtraction angiography, and you can see the size of this vessel. It ruptured somewhere at the top, locally tamponaded, and the patient hasn't died yet. They need treatment quickly. because aneurysms have a high rate of rebleed after the initial bleed, up to 30 to 50% over the next 48 hours. This is a young female patient, oral contraceptive pill. She's got no reason to have a lobar hemorrhage, so this you cannot dismiss as just a primary hemorrhage. And we can see a rapidly evolving lobar pattern, sort of multiloculated. Some people liken this to cloves of garlic appearance. And the clue is on this first image. We have a hyperdense cortical vein here, a little bit of probably subarachnoid blood here, and a slightly hyperdense sinus posteriorly. MR venography is, everyone thinks that MRV is the way to image dural venous sinuses, and that's largely because historically it was the first way we were able to image them other than catheter angiography. In reality, with modern CT venograms are a more robust and easily interpreted study. MRV has lots of artifacts it's hard to get to. CTV is quick and easy, and it looks like what you expect it to look, which is normal blood with contrast, appears very hyperdense and uniform. Clot within sinus appears less dense than this. And so this patient had a superior sagittal sinus, a thrombus up to here, which also extended out into that cortical vein, which was the area of the brain that then still had arterial inflow, but didn't have venous outflow, and something burst. And that's why it's often multiloculated, because multiple vessels burst. Another youngish patient with a large bleed, and a lot of the clues don't come from the centre of the clot, they come from the periphery. So if we start over here, again we have an area that doesn't look quite as dense, and there's a speck of calcification. Now, other than neurocystosarcosis, there's not really many things that calcify within the brain parenchyma. If you look at the margins, there's more blotchy areas that are not as dense as the rest. And this patient had an arteriovenous malformation. Again, the clue is that this patient has no business having a primary hemorrhage. They're not elderly, they're not hypertensive, you have to look. And again, these lesions rebleed, so if you were just to, for some reason, not investigate them further and send them off, the next time when they recover, they're going to bleed and die. And this is a catheter angiogram showing injection in the internal carotid artery with middle cerebral artery branches, feeding this nidus of an arteriovenous malformation. And one of the features that you'll see with arteriovenous malformations is that they are shunting lesions. So blood goes straight through the malformation and into the venous system really quickly. So if we have a look at this study, you can see venous blood with contrast in it, draining through the superior, transverse and sigmoid sinus, before any of the brain has even reached capillary stage yet. The rest of the brain is still starting to meander down cortical branches. Now, a further case. Just as Andrew was saying that horizontal or very straight lines are something that is a worrying feature, that usually the body doesn't have those sort of shapes, a very well circumscribed bleed is something that you need to also worry about. And that's because if you bleed into normal brain, the brain has axons and various structure that will track blood into different directions, and you'll always end up with an irregular outline. When you have a very circumscribed lesion, you have to worry that this is blood into a lesion rather than just blood on its own. And you have to stop focusing on the big, bright thing that you first notice and look at the periphery. And if you start looking posterior to this lesion, which has some edema around it, you'll see this area of density within the white matter. White matter on CT should be less dense than the overlying cortex. And if we follow it down a little bit, we can see this abnormality following it across. Contrast is your friend. The brain receives a lot of blood, so it will change its appearance with contrast. Give contrast, and now you see that next to this lesion is a peripherally enhancing lesion with more not particularly enhancing tumour extending across the corpus callosum. So this is hemorrhage within a glioblastoma, or GBM. Not terribly commonly do they bleed so macroscopically. A small amount of blood is really common. But again, you need to be aware that there's an underlying lesion. Treatment will be very different. For a lot of these lesions, the next step is an MRI. MR is something our radiology trainees only get most of their exposure towards the end of their career. It's complicated. It's not really one modality, but like a dozen modalities rolled into one, with each sequence appearing different. So we're not going to go over very much MR at all today, other than to let you know that sometimes you can't make the diagnosis on CT. it needs the next test, and the next test is usually MRI. We are going to be running an adult brain MRI course in end of August, so that's the one and only plug for the next conference, which will be almost entirely devoted to MR, and hopefully will shed a bit of light. But we can see that this same tumour, here's the blood, here's the edema surrounding it, and non-enhancing tumour spreading across the midline, characteristic of a glioblastoma. One of our international questions, is it possible to differentiate in traumatic patients with subarachnoid hemorrhage, which is first, the subarachnoid or trauma? At first you'd think that that would be relatively straightforward, but the problem is that if you have a subarachnoid while on top of a ladder and then fall over and hit your head, you will have traumatic injuries as well. So what leads to your bump on head, fractured skull, hemorrhagic contusions and traumatic subarachnoid might all be due to the fact that you transiently lost consciousness from a primary subarachnoid. So the most important thing is a good story. So if the person was walking along and collapsed for no good reason, you're not going to believe that it's all traumatic, unless they have a history of epilepsy or something, I suppose. Whereas if they were up a ladder and the ladder tilted over and you saw them, they were conscious until they smacked their head on the concrete, then you're more likely to attribute all the findings to subarachnoid in the setting of trauma. The other important feature is pattern recognition. So most of your aneurysm occur around the circle of Willis, 95% plus. So that's where most of the blood will be. It's very uncommon to have subarachnoid blood purely up the top. It's not unheard of. You can have mycotic aneurysms, you can have dural arteriovenous fistulas. But when that's in the setting of a good trauma, you have a lump on the scalp, you might have a fracture. Here we have lots of hemorrhagic contusions, and the only subarachnoid blood you see is tracking in the region of maximum traumatic injury or in a contra-Q distribution, so on the contralateral side, not in this case, then you can be more reassured that there's no underlying lesion. Again, with the advent of CTA, the threshold for looking has been reduced, because you used to have to put a needle initially directly into the carotid, for any of you that have seen the original Exorcist, or more recently through the femoral artery, which carries a stroke risk itself and complication risk. With the CTA, you only really have the contrast and the radiation dose to worry about, and it's a small price to pay if you are uncertain. Hemorrhagic contusions start off small and then they get bigger. Even if the amount of blood doesn't increase, and often it does because it seeps out of burst brain, the amount of edema surrounding them will increase. And we'll see that later on, that a lot of the damage that injuries or processes in the brain causes is not directly but indirectly through swelling within a confined compartment where there's no room for brain to go, so-called secondary injury. Another very quick question from Jano in Finland, whether you just scan CT brain and CT spine in one go or whether you do it separately. And this gets back to a number of the questions that we've had today about, do you give contrast, do you give IV contrast, what sort of scan do you perform? There's always this balance between radiation dose and how good your imaging is. You need to get imaging that's good enough to make the diagnosis, because even a tiny bit of radiation for a scan that doesn't allow you to make the diagnosis is wasted. So you need to make sure the images you get are good enough. And the problem with cervical spine is the shoulders. Getting down to the shoulders, it takes a lot more photons to get through to get good imaging. So you can reduce your dose to the brain and then increase your dose through the shoulders by doing separately. Someplace, depending on the scanner that you have, you might be able to get away with it, but we do them separately, and in most places do them separately still. There's also the speed component. You might need to do it really quickly, in which case you might do it all in one go. Now, on to extraaxial hemorrhages. The key to understanding extradural, subdural and subarachnoid hematomas is understanding the anatomy of the dura, which sounds a little bit dry, but we'll work our way through it. It's not as bad as you might think. So the dura mater is really composed of two layers. This green layer, which is the visceral layer, which is the one that's the true dura mater, it belongs to the brain, and the parietal dura, which is actually endosteum. It belongs to the bone. It's exactly the same as the periosteum, and it's continuous with the periosteum that goes through sutures where bony fusion hasn't occurred. These two layers are in life fused. You can't separate them out. So there's no hematoma that occurs between these two layers. The only place where these layers aren't fused is where you have dural venous sinuses. And sinuses live between these two layers. And here we have an arachnoid granulation leading into the sinus to allow CSF absorption. When you zoom down a little bit more onto this sort of area, you'll see that there's another couple of layers. Immediately abutting the visceral layer of the dura on the inner surface is the arachnoid layer. And this gives off, it's single cell, it's transparent, and it gives off these little strands of tissue down to the brown layer here, which is the pia mater. And the pia is stuck to brain. You can't have a bleed deep to pia, it's just a parenchymal hemorrhage. And so this is the subarachnoid space. This is where your subarachnoid hemorrhages occur because this is a space where your cortical arteries and veins are running. Now the next picture is a little bit gross, so I hope none of you have a particularly easily frightened stomach. But this autopsy specimen just demonstrates the relationship of these layers. So the skull has been removed, and here we have the dura mater, 2 layers fused, and it's been peeled away from the arachnoid that remains intact. And you can see that pus, because this is bacterial meningitis, is trapped in the subarachnoid space, just in the sulci, but not on the surface. So the space that's been opened between these 2 layers is the subdural space, which is a potential space that usually doesn't contain anything. And that tells you how the appearance of these 3 bleeds will be determined. Extradural hematomas will tend not to cross suture lines because it's essentially and subperiosteal hematoma on the inside of the skull. So it'll be limited to the bone that it affects. So where there's a suture line, they tend to stop unless that suture line is involved in trauma. And they tend to have this lentiform appearance, so biconvex. See this heterogeneity of signal? This is very acute blood. It hasn't quite retracted and clotted and become hyperdense yet. A lot of mass effect. Subdural hematomas, in contrast, are deep to the parietal dura, so they will track around dural sinuses, and they won't care about sutures. They'll just go wherever the surface of the brain is. But importantly, they won't extend into the sulci because that's subarachnoid space. They typically have a sickle cell shape, not biconvex, but this sort of crescent moon appearance. And you'll see it tracking along the falx. And subarachnoid, well, it's in that space where we saw the pus before, so it'll fill all the sulci. There won't be a subdural space to compare it to, but the vessels will be within it. And so on imaging, you'll see hyperdensity extending down into these sulci. So let's have a look at a few of these examples. So lentiform appearance. Had a bit of a hit on the head. They've actually got a hemorrhagic contusion as well, just here. So they've had trauma. And if we got a bone window, you'll see here's a fracture. That tiny little groove just there is the groove left by the middle meningeal artery. And the most common cause for an extradural hematoma is a fracture going through the middle meningeal artery and causing an arterial bleed. That's why their typical clinical presentation is they get hit on the head, they're transiently okay, but bleeding is starting. And it's starting to strip off that endosteum, the dura, and creating a mass lesion that gradually compresses the brain, and then they become drowsy and lose consciousness. It's arterial, it's under high pressure. Young patients will die quickly from this if they're not decompressed, but if you decompress it, the underlying brain is okay, and they do very well. And if we just look at this, you can see on bone window even where that hematoma is. It crosses the fracture, but here's the suture, and it's not going past that suture anteriorly. This is a much larger hematoma, again, limited by the suture anteriorly and posteriorly limited there. We see some gas in here, so that tells you somewhere along the line there's got to be a fracture. And there it is. This suture is splayed or enlarged due to a fracture going through. And here's a further fracture. And where does the air come from? Well, unless you've got an open laceration of the scalp, you need to track the fracture inferiorly down to the mastoid air cells, because that's where the air will have come from. And sure enough, there the fracture goes through the mastoid air cells with a pacification of the mastoid air cells and middle ear cavity. You won't be surprised to know that this patient's probably not doing very well by now. The amount of midline shift is dramatic, and it's made worse by the fact that this ventricle now can't empty, so it's still producing CSF, and it's adding to the pressure effect. So they need emergency decompression, and we hear about, brave GPs doing it clinically up in the bush because you don't have time to transfer these people down. They're almost always arterial, except when they're not, and they're rarely due to venous. And when they're venous, it's usually because there's a fracture that involves one of the dural venous sinuses. And here we can see this linear fracture going through the vertex, and it's torn the superior sagittal sinus and the resulting extradural hematoma. And that's the sinus displaced inwards, because remember, the extradural is outside of the sinuses, it's subperiosteal. In contrast, subdural hematomas have this shape that we saw before. And if you see this kind of appearance, you might be wanting to call this acute on chronic, and you see this often the case. And the reality is that this is a very acute hematoma. And if any of you have seen a couple of 100 mils of blood in a kidney dish during surgery, it clots, but not all of it. It doesn't clot as a complete block. There's usually some serum that's expressed. So that's the serum, that's the clot. That's the midline shift. And again, we have hydrocephalus. The best place to look for hydrocephalus is the temporal horns. They will be the first ones to go up. You need to get an eye in to know what's an appropriately sized temporal horn for that age group. But here they've got a degree of compression from hydrocephalus and therefore downward herniation. Note that the uncus, the medial part of that temporal lobe, is filling that recess and deforming the midbrain. It's really hard to see even where the CSF is. This is more of what you would see in an acute on chronic subdural. So this patient, usually elderly, they will have bumped their head months and months ago, had a small unknown subdural, and like all blood initially starts off as hyperdense and then gradually becomes less and less dense until it's almost CSF intensity. And then they bump their head again and they get a fresh bleed in it. And the blood is heavier than just serum and sinks to the bottom. The one caveat with that is that if your blood is anticoagulated, it will also do this. And you know this because when we send off FBEs, we do that in a heparin tube where we deliberately stop the blood from coagulating. And if you let that settle, it'll settle into a hematocrit. And so that might be what you see if the patient's on warfarin. Does it really matter? No, not really, because they've got a big subdural that's causing mass effect and it needs to be evacuated. Again, a lot of midline shift. This is the pineal gland. It calcifies normally by the time you're about 30 or so, and choroid plexus similarly calcifies normally. They're not abnormal calcification. And before we had cross-sectional imaging, looking for shift of the pineal calcification was one of the ways to be able to tell midline shift. And again, look at that temporal horn. It's distended because they have hydrocephalus, and again, that uncus, mesial temporal lobe, is herniating medially, distorting the right cerebral peduncle. It can push it so hard that the contralateral cerebral peduncle impacts upon the free edge of the tentorium and can give contralateral neurological deficits. Where you can be certain that it's a chronic subdural is where you have these sort of layers or fibrinous bands through a subdural. Remember, they have a clot which is filled with red blood cells and fibrin, and that can organise and form these sheets of fibrinous material. And this is what it looks like. Here there's some more fresh clot within a fibrin compartment. And this drives the neurosurgeons nuts because you'd love to be able to drain this just through a burr hole. But if you just put one little burr hole here, you'll drain this pocket. And so often these patients are difficult to drain and may require a craniotomy to do it. The other problem with chronic subdurals is the brain has been compressed for a long time, so when you evacuate it, it doesn't just spring back up immediately. It takes a long time for it to re-expand, and they can get recurrent subdural collections because there's just nothing to take over that space. You can nurse them head down and give them lots of fluid boluses, etc. From Ahmed in Egypt, how can I differentiate between normal hyperdensity of the tentorium and abnormal one, shown subarachnoid? This was usually more of a problem before we had routine cross-sectional CT. When, not that long ago, CTs were just producing axial images. And so the tentorium slopes on either side, like a tent, and you're cutting through it at an angle, and depending on the tilt of the patient's head, one side would often look a little bit hyperdense to the other, and it was quite hard to be able to tell. You'd have to look for subdural elsewhere because usually it tracks up along other compartments. But now that we routinely image brains volumetrically, so we acquire a whole volume with each voxel or 3D pixel being somewhere in the order of 0.6 millimeters, you can reconstruct it in any direction, and we routinely have coronal and sagittal. And so here we can easily compare the two sides, and this tentorium on this side is thickened. So there's some subdural blood probably on the surface here, and subarachnoid on this side. Sometimes you can get meningioma that looks very similar, en plaque meningioma, so it's not always certain. And dura can also thicken, maybe from previous insults or just as part of aging, or it can even calcify. But the key is to look at it preferably in coronal where you can compare the two sides. All right, the first of our quiz cases, 68-year-old with headaches and confusion over past weeks. What abnormality do you see? Now, winner is Yao Sheng Ho. Are you here? Come on down. Now, this one's a tricky case where only a few people got this one right. And Xiao also, you did very well on pretty much every answer you gave. So come over and tell us. We'll just pick one slice, huh? All right. What's the abnormality?
I mean, it's bilateral. Subdural hematoma is probably around 7 to 20 days old.
And how do you know that that's what it is?
Because it seems like the white matter has been pushed medially on both sides. The cortex looks thicker than it should. And the hematoma, which would be on the outside, is isodense to the grey matter.
Well done. Excellent. Grab yourself something. So this is one of those classic traps. Okay? Once you know what to look for, you can see it and you won't make the mistake. But here you have the full gamut of traps because you have bilateral equal size subdural collections. So there's no midline shift. There is shift inferiorly. So if you look at that uncus that we've pointed out before, it is a little bit medially displaced, but not terribly much. Downward herniation without midline shift can be hard to see. And subdurals, we said, they went from very hyperdense to very hypodense, similar to CSF. That means at some point they have to be intermediate, and they go through a point where they are isodense to cortex, and you can't distinguish the two. So the clues of it are the white matter should come out about a cortex amount away from the inner table, right? Because all that there should be between white matter and cortex in a full brain, white matter and bony cortex in a full young brain is brain cortex. In an older patient, well, that's easy because there's going to be lots of CSF surrounding it. But here, the closest white matter you can find is back here. The other thing is, even in the youngest, plumpest brain, you should have little triangles of CSF which are pointing down a sulcus. And their base should be on the cortex and they should be pointing down into a sulcus. We're not seeing these at all. So you can make the diagnosis on this. If you're not certain, you can give contrast. Because remember, brain takes up a lot of contrast, so the cortex will change density. And you'll recall that the subarachnoid space is where all those vessels are. So if you can opacify some of these vessels, you can see that they've been displaced medially, because this is a subdural collection, so the subarachnoid space has shifted medially as well. MR obviously can give you the answer, but by that stage you will have probably sent the patient home if you haven't recognised it. So bilateral mass lesions in the brain, you underestimate the amount of mass effect they're having because there's no midline shift. And we're also tied to the idea of midline shift as an indicator. So beware of any bilateral process. And our next case was of a 68-year-old woman with sudden onset headache, nausea and vomiting, diagnosis. Jade, you here, Jade? Nope. Thank God for that, because I think we're going to be one bottle short. And the diagnosis here, most of you guys got it right, or the people that answered. Jade got the prize for being quickest off the mark, which probably says more about OCD behaviour than it does about clinical acumen. Well done, Jade. OCD people unite, I'm one of you. More than you might guess, or maybe not. Anyway, we have subarachnoid hematoma here, or hemorrhage. a lot of it. And remember how I said most of the aneurysms are around the circle of Willis, so most of the subarachnoid blood will be around the circle of Willis. Here we have it outlining the suprasellar cistern, outlining the midbrain, extending out along where the middle cerebral artery branches would be. And note that it's asymmetric. So you can take a punt as to where the aneurysm is going to be. In these days of CTA availability, that's not so important, right? Because why try and guess when you're just going to find it? It used to be really important because surgeons would go fossicking around like pigs after truffles to try and find the aneurysm. But now you find it. The problem is, for every patient that has one aneurysm, 1 in 20, 1 in 10, something like that, will have a second aneurysm. And you have to identify which one's the one that's bled. Often that's really obvious because one of them will be tiny and round, the other one will be horrible and big and have clearly areas that are blown out. But if you can say prospectively, most of the blood is here on the right, it's either going to be a terminal ICA or posterior cerebral artery origin or middle cerebral artery origin aneurysm. It's very helpful when you then find another incidental aneurysm. And here we have a posterior cerebral artery aneurysm, just to give you an idea of some of the other modalities that we'll have. There's a catheter on the internal carotid artery, lateral projection. That's the pituitary fossa. The orbits are over here, sphenoid, sinus, and mastoid, inner ear. And contrast is injected. You can see it flowing up the artery. And just where the posterior communicating artery gives off is this inferiorly pointing aneurysm. And this is one of the very common aneurysms, and usually it's amenable to treatment endovascularly. So a microcatheter, you can see the point of the microcatheter here, has been advanced up the internal. This is at the end, so it was actually in here. And the aneurysm is filled with what are called coils, which are small platinum or metallic wires that form a ball, and blood clots around them, and eventually that endothelializes. Much nicer than having a craniotomy. But some aneurysms aren't amenable to endovascular treatment. This is an important pattern to recognise, and again, this is important because what you don't want to do is for this patient to be misdiagnosed as having a basal ganglia hemorrhage and be sent up to the stroke ward to recover, because within 48 hours they have a high rate of rebleed because this is aneurysmal. This is what we call a flame-shaped hematoma. It always points, starting from where you expect the anterior communicating artery to be, and points away from it anteriorly towards sort of 11 p.m. or 1 p.m. and up into gyrus rectus, or the floor, the inferior part of the frontal lobe. And that's because that, again, we see the filling defect that we spoke before of unclotted blood within an aneurysm. These aneurysms can become adherent to brain, sometimes because they leak a little bit, or sometimes there's just a little bit of inflammation from it stretching. And the brain becomes adherent, and when they rupture, the blood, instead of going into the subarachnoid space, gets into that subpial space or intraparenchymal space. And so much so that in some cases you won't have any subarachnoid blood. It'll all be intraparenchymal. So a hematoma that's intraparenchymal leading down towards where you expect aneurysms to be is a red flag and should warrant CTA, just to exclude an underlying lesion. And this person had a catheter angiogram, again showing an ACOM here. Catheter angiography now has the ability to do 3D reconstructions, which are great for helping to plan coil selection and as well as planning surgery if it's not amenable to coiling. And the flames-shaped hemorrhage will point usually away from the aneurysm in that sort of direction. And this morphology is very common, where they have a very dominant anterior cerebral artery on one side that supplies both anterior cerebral arteries with not much on the other. If you injected the other side simultaneously, you'd see there'd be a hyperplastic A1 segment here. And because of the increased flow, that's where the aneurysm arises from. About 30% of all aneurysms will be anterior communicating artery aneurysms. This is the pattern of subarachnoid blood where it's hard to know when to stop imaging the patient. But you usually get a clue clinically. This was, I think, a 70-year-old guy working in the shed, lifted something, got sudden onset headache, worst headache he's ever had, but that's about it. He didn't collapse, doesn't have any neurological deficit, went inside, poured himself a double shot of bourbon or whatever, sat home for a while. His wife eventually told him that he should go see someone, comes into the emergency department, you do the scan, and you see all this subarachnoid blood, but he's sitting up in bed. He might be a little bit annoyed by the bright lights, but that's it. And you can do as many vascular imaging as you want, you won't find an aneurysm in these patients. This is a perimesencephalic subarachnoid hematoma. It's probably venous. They don't rebleed usually. They don't get vasospasm. But you can't just say that. So you will do a CTA, and at our institution at Royal Melbourne, we will then do a catheter angiogram. We'll do an MR with an MR angiogram. Then we'll probably repeat a CTA or MRA at some point, and then as an outpatient, repeat it again. Because one of the things that can happen is very small vascular malformations, including aneurysms, can transiently be compressed or invisible due to clot. And so before you give someone a clean bill of health, you need to know there's nothing that needs to be treated. Because if they rebleed any of those lesions, the next bleed you're usually not as lucky. But this is a very typical pattern, and it's usually centred here in the interpeduncular fossa, just behind the clivus, between the two cerebral peduncles. Another cause of subarachnoid hemorrhage, which is, believe it or not, even worse than aneurysms, tends to occur in the posterior fossa. And here we can see vast quantities of subarachnoid blood surrounding the upper cervical cord and medulla, extending into foramen of Magendie at the back and Luschka on either side, filling the prepontine cistern. And there is a little bit up here, but not a great deal. Temporal horns dilated, so obstructive hydrocephalus. CSF can't get out of the fourth ventricle, but still being produced. Blood has even refluxed back into that intraventricular compartment, through those foramen, through the fourth ventricle, up the aqueduct, through the third, through foramen of Monroe, and now is lying dependently. Another horizontal line that tells you something bad is happening. And the cause, when you see a lot of blood in the posterior fossa, can be a posterior inferior cerebellar artery aneurysm, or it can be a vertebral dissection, or in this case, a dissection of the pica. And the problem with intracranial arteries, unlike the rest of the body, when you get a dissection anywhere else, and Andrew showed a big aortic dissection, they occasionally rupture. But mostly the pathology comes from occluding vessels. So the dissection flap will occlude a branch to your kidney or to your bowel or to your leg. And they don't really rupture that often because they have a very thick and well-formed adventitia, the outer layer of the arteries. Intracranial arteries don't have that. They've got endothelium, media, and that's it. And media is made of smooth muscle. It's a lousy structure to sort of contain a hematoma. So once you breach the endothelium, they have a high rate of hemorrhage. And when they bleed plenty, and patients tend to die. The other thing that makes them challenging is dissections evolve over time. And the initial dissection that leads to the bleed may not be apparent on any of your initial imaging. And so this is another situation where the pattern of hematoma leads to repeated investigation until you can really convince yourself that there's nothing going on. And we would not infrequently perform 2 or 3 catheter angiograms on these patients until we believe that there's no dissection under there. Treating these is also a nightmare. You usually have to sacrifice the vessel because you can't reconstruct them, and so they end up with an infarct of the distal vessel. So that's it for bleeds. All right, have a breath. We're now going to launch into stroke. I hope you all got that. I also am a card-carrying member of the Nerd Geek fraternity as well as being OCD, so that's one of my favourite jokes. I don't do bar mitzvahs or parties. Ischemic stroke. Ischemic stroke can also be divided into 2 bits. It's a very uneven division. We have global hypoxia on one side, which doesn't occur very often, and end artery, which in the end artery can be circle of Willis, so you can occlude the top of your ICA, for example, or the top of your basilar. It can be a cortical branch, or it can even be perforators. And the majority of end artery strokes are going to be embolic. Now, before we go on, there's just one thing that if you guys take this away from you, it'll serve you well for the rest of your career. Lacunar infarcts versus perivascular spaces. We have this feeling that lacunar infarcts somehow don't matter, but in fact, once I've identified a patient that's had a proper stroke, a stroke that's killed off a bit of their brain, that should alter their medical management significantly. And their rate of stroke in the future is really high because they've had one. Whereas if you've got a perivascular space, that's a normal bit of anatomy. So not confusing the two is important. The best rule for this is where is it? So lacunar infarcts are end artery perforator infarcts. So they will occur at the end of these perforators that have arisen, in this case, from the M1 branch or middle cerebral artery. They'll occlude somewhere along here and you'll get a bit of dead tissue up here. So top of thalamus, caudate, putamen, they're the typical locations. Perivascular spaces, on the other hand, are just where CSF is coming up along the side of the artery and it just balloons out. So that occurs below this sort of midline level that you can draw through the lentiform nucleus. So anything below this is most likely going to be a perivascular space. It means absolutely nothing, it does not cause symptoms, will not cause symptoms, it's normal. Anything above this shows that this patient has had a bit of brain that's died from a vascular event, means a lot. In terms of how it looks on CT, very hard. In terms of the actual hole, they look quite similar. Lacunar infarcts tend to be a little bit more spindle-shaped because they're sort of a little cleft and then the brain around it contracts. They can be a little bit ill-defined, like this one, because there's a bit of gliosis around it, a bit of a scarred brain tissue. And note the volume loss. Here the thalamus is a little bit concave instead of convex. They're kind of subtle things. You want to get your radiologist to come and tell you if you're not certain. Perivascular spaces won't usually have any mass effect, don't have any gliosis. And you sometimes, like in this case, yeah, you can sort of see there's a little vessel coursing through it. So we get to do this question. Which of these infarcts is due to a perforator occlusion as opposed to an end artery cortical branch? A, B, C or D? You're all very shy today, but we have a standout winner. You have to be really brave to go C or D at the moment, don't you think? All right, so perforator is correctly answered as B. So this is a little perforating branch, a small twig that comes off at right angles from a main branch, in this case the basilar artery, and supplies part of the pons. Note how it doesn't cross the midline. So that's a great sign in the brainstem that this is a vascular lesion. If it has a really sharp midline demarcated edge, this isn't a tumour, it's not an abscess, it's not demyelination, this is an infarct. All these other ones are due to large vessel occlusion. So here we have a posterior cerebral artery, PCA infarct. Here we've got your favourite MCA territory infarct, most common, just because it gets the majority of the blood, so clots will preferentially go down it. And here we have a pica infarct, posterior inferior cerebellar artery, and we'll get to have a look at some of the complications of that in a second. If we could, we'd have MRs available in ED everywhere, because MR is probably the best way of imaging stroke. DWI changes will occur within seconds or at least minutes of occlusion. It's a great way of predicting infarct core versus penumbra. It's got lots of other benefits. The problem is getting a patient quickly into an MR is hard. One, because there's lots of safety issues, and two, there's just not that many scanners around and the protocols are much longer. So the bulk of what we image is CT. And for years, all we had really was non-contrast CT. And the first thing that we got taught is this hyperdense artery sign, usually the middle cerebral artery. And this is direct visualization of the thromboembolism that's come from your carotid or your heart or wherever it's come from. It's gone up and impacted into that artery. And you would see that immediately because embolisms have formed somewhere else, they've had time to mature, they become hyperdense, then they dislodge, they flick up. Heart, carotid, paradoxical if you have a patent foramen ovale. So you might have a clot in your calf that goes through the right side, then into the left side of your heart and up. That's probably the most common in young patients. So a lot of young patients who get an ischemic stroke need an echocardiogram to look for a patent foramen ovale or another shunt. Aorta, if patients who are getting coronary angiograms with the wire and catheter flicks parts of the atherosclerotic wall off, or cross-clamping of the aorta during coronary artery bypass grafts would be some of the more common causes. Occasionally vessels intracranially just thrombose, and usually that's in the setting of intracranial atherosclerosis, which is more common in Asian populations, and the plaque, like everywhere else, ruptures and you get thrombus over the top. The trick with that is acute thrombus, as we saw, really acute thrombus, isn't hyperdense, so it's much harder to see on non-contrast imaging. And we spoke of dissection. It can bleed, it can also occlude the vessel. So hyperacute findings, and this is hopefully what you're looking for, because hopefully we're getting patients from the community into hospitals that have stroke management within minutes, ideally, under an hour, hopefully. So direct visualization of the clot will occur immediately. This is just the clot that's stopped there and you're seeing it. And early parenchymal signs. So in this case, you can see that the caudate head here is less dense than the caudate head here. And as Andrew was pointing out, when tissue gets unhappy, it becomes edematous. You add water to brain, it drops in density. We know that water is this density, right? So you stop seeing grey-white matter differentiation. Similarly, here is the putamen, gone. Here is the insular cortex with white matter subjacent to it, gone. So this patient already has parenchymal signs. And so the idea that parenchymal signs only show up after 6 or 12 or 24 hours, which you'll hear people say, is just wrong. You just need to look carefully. And those ones will come quite early as 1 hour. And in these areas, because these are the bits that are furthest away from collateral circulation, so there's no blood coming in from elsewhere to help, these lesions are the ones that will occur earliest. And within 3/4 at 3 hours, you'll see it. So at 3 hours, this is still within a window of therapeutic intervention for clot retrieval. Surface cortex, though, supplied by cortical branches, because there's usually collateral circulation, will take much longer to become apparent. So the days of ischemic stroke being a hand-holding, there, you don't have a hematoma, go and get over your hemiparesis and rehab are over. We now have strong evidence-based findings that retrieval of clots in acute patients saves lives with very little added morbidity. Just in the past few months, a number of studies have come out in New England Journal, Lancet. Some of those were from here, from Melbourne, from Royal Melbourne, in fact, contributed to them, showing that if you go early enough within 3 hours into these patients who don't have hemorrhage and don't have a completely established large core infarct, and you pull back the clot, they do much better. And that has completely changed stroke management and really has laid down a challenge to any hospital that doesn't offer expedient stroke management as to why they should be receiving stroke patients. And of course, it makes enormous challenges for anyone living rurally where transport is an issue, and for the rest of the world who's not as lucky as us to have interventional radiologists with expensive retrieval devices. But so your non-contrast hyperdense artery, CTA shows filling defect and perfusion. So perfusion is looking at which parts of the brain are receiving blood, and it's semi-quantitative, so you can actually get some numbers out of it. And you can identify which regions of the brain are physiologically not getting enough blood. So this is what most centres who do stroke intervention would call a stroke protocol, and it involves all three. And the challenge is to get this done and read and interpreted extremely quickly so that you have time to call people in from home if it's overnight to retrieve the clot. So a quick case. Hyperdense MCA does not have to be just the M1 segment where you see it horizontally. It can be further up in these sylvian branches. And so this is a little cortical dot. Not convincingly seeing any loss of grey-white matter. You'd want to look further up because it'll be distal to this. So we perform CT perfusion, which gives you a bunch of variables. This is cerebral blood volume and cerebral blood flow, which just show how much blood is going through there with contrast. Blue is bad. And we have Tmax or MTT, which are measures of how quickly blood is flowing through this area. So the how quickly is a measure of at-risk brain, and how much is a measure of dead brain. So we know that this is all dead brain. There's nothing you can do about it. You can't see it yet on CT. Treating this clot will not help. But they might get worse. So if you try and treat this patient with IV thrombolysis or clot retrieval, you're not going to save brain, but you might get hemorrhagic transformation. That might happen anyway, but by giving them TPA or retrieving clot, you increase that chance. And then you run into the problem that you have someone with a stroke and a hemorrhage and mass effect, and it's a much bigger deal. And you have enough problems with just a non-hemorrhagic transformation if you've got a big stroke. So this is a large middle cerebral and anterior cerebral artery stroke at day 3. That's about starting to get maximal swelling So much so that one of the therapies is to remove part of the skull, so decompressive craniectomy, to let the brain swell outwards under the scalp, and then it can recede. And here at day 11 we can see some of that swelling receding, midline shift coming back from normal. This is a problem supratentorially. It's even more of a problem infratentorially because one, there's less room, and two, you're compressing the brainstem. So patients go into Cheyne-Stokes breathing or just die. And here's the patient with posterior inferior cerebellar artery territory infarct. We know this is established, 12 hours old at least. It's probably older than that because there's a lot of swelling. And you can tell that because there's no CSF left in front of the pons. That's the basilar artery squashed up against the clivus. And this too is a medical emergency. We can see they have hydrocephalus. Look at the size of those temporal horns and how little CSF there is surrounding that. And this is one of the few situations in which resecting infarcted brain isn't indicated. So surgeons will go in and perform a posterior fossa craniotomy and resect a lot of that dead tissue to decompress the brainstem. The word ischemic penumbra has become really key in understanding which patients are going to benefit from therapy. And so understanding it at some level is important for any doctor. And so this would be the full set of CT perfusion data. As I mentioned, these two are measures of at risk, blood not flowing through the brain fast enough, and these give you an idea of how much blood is actually going through. And remember, what the brain cares about is it needs to get enough oxygen, enough glucose, and get rid of enough CO2 and other metabolites to stay alive. It doesn't really care whether it gets a lot of slow-moving blood or narrow vessels with fast-moving blood. So CB, cerebral blood flow, is the key metric. So if we have a look at a simplified brain, very simplified, so this is the tissue at risk. This is the area that has blood flowing to it far slower than it should. This area of darkness is where it's not getting enough. This is dead brain. Doesn't matter what you do to it, it will die. This is the area that on DWI would be bright on MRI. Everything between the two is brain at risk that can be salvaged if you reperfuse it. This brain is holding on due to collateral circulation from posterior cerebral artery and anterior cerebral artery. So if you remove the obstruction, these patients can save this enormous volume of brain. Now, not all thromboembolic events go to cortical branches. Some of them fly up the basilar. And instead of patients presenting hemiplegic, they'll present unconscious, top of basilar type syndrome. And if it's incomplete, it might be a difficult transient unconsciousness. You need to have a high index of suspicion. But whenever there's the concern that there might be basilar occlusion, you need to look at your non-contrast studies very carefully. And the key is to look for hyperdensity at the top of the basilar. If we just scroll down, see the difference in density? So this is the opposite of the CTPA Andrew showed, where you've got a vessel that suddenly changes density. Top of basilar is another endovascular emergency. If you can fish this out, you can save a life, hopefully. Unfortunately, the brainstem doesn't take very long to die, but you don't have terribly much to lose because they're either going to die or, even worse perhaps, depending on your point of view, you could end up locked in, where the famous patients that are able to hear and see and understand everything but can't move anything, or maybe they can blink or something. So look for this. If you've got coronal and sagittal imaging, look at those. They really help to tell whether it's partial voluming or motion artifact. And if in doubt, do a CTA. It's an easy pick with CTA. Another cause of bilateral thalamic central infarction or hemorrhage is outflow problems. So top of basilar is blood not getting into it, or you can thrombose this internal cerebral veins here. See how hyperdense they are? And here, compared to some other vessel. So you've got internal references. If you're uncertain about how dense something should be, don't measure it with the density measurement. Look at something that you know has the same value as it. So here you look at the blood inside the ICA compared to these, and these are hyperdense. You can already see some swelling and edema of this right thalamus. CT venogram is your friend, easy to do, easy to interpret. And here's an extensive clot all the way through internal cerebral veins, vein of Galen, straight sinus, and probably that's a little bit into the outgoing transverse sinus. Unfortunately, the next day they've got bilateral infarction. Now, it's critical to identify patients with venous thrombosis, even those that have large parenchymal hematomas, because the treatment is heparin. Now, you would not dream of giving heparin to someone who had a primary intracerebral hemorrhage from amyloid, but in venous infarction, heparin is the first thing you want to give them. And usually there's no real interventional retrieval mechanisms yet developed to treat these successfully. TPA might help. When you look at this, the first thing you might think is that they've had a massive subarachnoid, because all the branches around the circle of Willis are bright. This is actually what we unimaginatively refer to as a pseudo-subarachnoid sign. These are exactly the right density, it's that the rest of the brain is low density. Remember, you have to be able to see grey and white matter as separate densities on a normally windowed CT brain. So if we try and identify a single structure, other than maybe the thalamus, everything's gone. There's no cortex, there's no caudate, there's no lentiform nucleus. This was an 18-year-old guy who had a arrhythmia and had a VF out playing soccer and got CPR for a bunch of hours before getting to it, and it was all too late. Sometimes, in his case, even his cerebellum is gone. Often the cerebellum continues to receive flow from the posterior circulation, and so the cerebellum looks really bright compared to the rest of the brain. And that's a helpful hint that something bad is happening supratentorially. This is not something that you should agonize over missing, because if you miss it, you're not missing much, right? Border zone infarctions are the last topic for infarctions before we have a bit of a stretch. And they occur between territories. We saw before where you have infarct core and penumbra, and the reason you have a penumbra is that cortical vessels are able to supplement that area via collaterals. So this would be your typical distribution: anterior cerebral, middle cerebral, posterior cerebral. Between here are areas where all the vessels are just getting to it. So if you drop blood pressure or you occlude a vessel, an inflow vessel further down, they'll be the first areas to become ischemic, because the central parts of the territories will still receive the bulk of the flow. So not surprisingly, border zone infarcts occur in this sort of distribution over the cortex, but there's also an internal watershed or border zone between perforating arteries and the cortical branches that come from above. So they'll also occur between these perforator territories, typically running just along lateral to the ventricle. And so if we have a look at this patient who was imaged incidentally for something else, had headache or something, we can see that in the past they've had cortical infarcts, bits of cortex missing with volume loss and gliosis. Here's another little chunk of cortex missing, and back here there's a gap. And if you look at the distribution, it follows that border zone between anterior cerebral, middle cerebral and posterior cerebral further back, with the central parts of all of those territories being very well preserved. They've also got chronic small vessel ischemic change, seen as patchy, low density change in the white matter bilaterally. But this should prompt you to wonder, why have they had a border zone infarct on that side? Why not both sides? Why at all? They've also had surgery before, I believe. They've got gliosis over here from something else. But if you do a CTA, having had your suspicion aroused, you can see they've got a very high-grade stenosis of that left internal carotid artery. So here's the common carotid artery coming to bifurcation, the external carotid branching off anteriorly and lateral, and internal carotid coming up with calcified plaque. CTA is very good these days at being able to look at the internal carotid artery for stenosis and is able to cope with pretty much any degree of calcification on modern scanners. So this patient, before they have an occlusion and infarct their hemisphere, you would like them to get some sort of therapy, and the therapy can either be carotid endarterectomy by the vascular surgeons or a stent placed by neuro interventionalists. All right. That's the end for that one. Have a stretch. Then we're going to do head and neck and spine and lumps and bumps. So tumours and other mass lesions. The brain is an amazing menagerie of lumps and bumps, which is what makes it so interesting. It also means there's no way we can systematically go through an overview of them. I'm going to pick and choose the important ones that you need to be aware of, and some take-home messages. Sometimes it'll be you really need an MR, and other times it's you should be able to work this out yourself. So these, I sort of just made these up. There's no real list. These are some of the common ones. You'll recognise these. We're going to try and cover most of these and really pick out the important ones which you need to know for your daily practice. And a few approaches. So here we have a middle-aged person with no history of tumour who presents with, say, hemiplegia or a seizure or something, and has a mass. This is the non-contrast CT, and the first thing you'll notice is it kind of looks like that hematoma that we showed before within a GBM, right? Because it's rounded, it's hyperdense. And again, it's too rounded to be a primary hemorrhage. This looks like blood in something. It's located at the grey-white matter junction, which is a great place for metastases generally. And if you give contrast, you kind of have to flick backwards and forwards. But look at this superior component here on pre-contrast and post-contrast. Okay, so this is a hemorrhagic lesion that is enhancing. The whole lesion is hemorrhagic. It's just interspersed in amongst viable tumour. And this is fairly characteristic of a handful of lesions. I thought I had a list. Here we go. The common hemorrhagic metastases are these four. These are the classic ones. When we say these are classic hemorrhagic metastases, what we mean are if you take 100 cerebral metastases from one of these, the majority of them will be hemorrhagic. But if you look at it a different way and you say, I have a hemorrhagic metastasis, what's it likely to be? You also have to include breast cancer and lung cancer. The majority of breast cancer metastases won't be hemorrhagic, but a significant proportion, say 5 to 10%, will be. And since there's such common tumours and such common causes of cerebral metastases, they are common causes of hemorrhagic metastases too. If you want to know whether something is a MET or not, if you can find a second one, that makes life a little bit easier. Okay? Very distant to this one, it's not a satellite lesion, it's a separate lesion, it's almost certainly metastatic. And now you have to find the primary. At many institutions, including my own, the neurosurgeons will go in and resect this. It's symptomatic relief. Recovery is surprisingly quick from a craniotomy. Patients can go home within 48 to 72 hours from an uncomplicated metastatectomy, and you get histology of the primary, and you've automatically staged them to stage 4 with metastasis in the one operation. But you sometimes do want to go fossicking, and knowing which lesions you're looking for, you can start having a look. This patient had an enormous lump, which was incorrectly called a colorectal carcinoma. Colorectal didn't appear on that list I showed you. It's not a common cause of cerebral metastases, and when it does, it's not hemorrhagic. And this isn't even of the colon's sort of running next to it. And we have lots of other lumps and bumps, including one in the subcutaneous tissue, which is a very unusual place for most of these to go to, with the exception of melanoma. And so you put these two things together and you can be very certain before the histology comes out of what the diagnosis will be. And this was metastatic melanoma. Another case where you just need to know that it exists so that you know where to look and you don't believe the report if it says just normal and you are looking for an abnormality. This patient would present with headache and visual loss. And the visual loss might be just bitemporal. Okay? And when you do a CT, you see that something's going on in the pituitary region. There's hyperdensity here that shouldn't be there, and it looks expanded. Bony views are more helpful to look at expansion of the pituitary here in coronal. This is remodeled, so this is an enlarged pituitary fossa. The thing that remodels and enlarges pituitary fossas or any bone is something that's been there for a long time, and the classic is a pituitary macroadenoma. And these have the tendency to hemorrhage, sometimes because you've given them medication to treat a prolactinoma, or sometimes just because they feel like it. And the patients will present with pituitary apoplexy. MR is your friend again because it's able to visualise the optic chiasm here, which is stretched over the top of this hemorrhagic lesion that's compressing it. This is a surgical emergency. The longer your optic chiasm is compressed, the less likely you are to regain function from it. So surgeons will be going into this within hours, usually, to decompress it, whatever time of day that happens to be. The other common scenario that you'll encounter is a patient that comes in with headache, typically in the morning, worse on straining, you know, your typical raised intracranial pressure headache, or a seizure, and you do a non-contrast study and you see a lump. There's no history of cancer. You give contrast, because contrast is a good thing to give, and you see a lump. You still just see one. The reality is you can't be certain of what this is on CT. They need an MR, and even with an MR, they will still need histology, but you need to identify that these patients are here. And what you see is, in this case, you have a low density component, and you have a lot of midline shift with that uncus pushed straight across. And when you give contrast, you see peripheral enhancement, it's nodular, it's ugly, and there's components that are thicker and larger. This is a typical appearance for a high-grade glioma. Remember, gliomas, low-grade, anaplastic and high-grade, or GBM, with GBM characterized by necrosis. So if you see a central area of non-enhancement in what looks like a tumour, it's probably going to be a GBM or a metastasis, and you need to go on to MR to prove it. This was a GBM, and seizure is one of the common ways that these present, and unfortunately, these also present in young patients. So take clinical considerations. If they don't have a history of cancer and they present with a seizure and they've got a big lump, it's likely to be the glioma. All right, another question, quick poll. Which of these peripherally enhancing lesions represents an abscess? A, B, C, or D? Well, I won't draw this out too much because it's a trick question. None of these represent an abscess. And I put together this slide a few weeks ago and then came back to it, and I thought, I think it's B. And I got it wrong as well, having forgotten that I was trying to be tricky. And this is another situation where at the end of the day you need an MR and you need a radiologist to look at it, and even a neuroradiologist struggles with these on CT because you need the full set of imaging. There are a few clues though. This is located where you'd expect a basal ganglia hematoma to be, and if you go to the patient and get a history that 2 weeks ago they became hemiplegic, that's what it's going to be. These other ones are much harder. This is radionecrosis. You'd have to get a history of radiation, but this could be recurrent tumour just as easily. And one of these is a GBM and another one's a metastasis, and I don't remember which is which. Here we go. So they can look very similar. Often there are telltale signs, but you can't expect to get them right all the time. So peripherally enhancing lesions, and I prefer this term to the ring enhancing because some people equate ring to that very smooth appearance that you see around abscesses rather than the lumpy, bumpy kind of peripheral enhancement of GBMs and metastases. And it's a long list. You need to ask the patient questions. Usually you'll figure that out from that. Sometimes you won't. But the one that you need to understand and be wary of is all the other ones can wait until you get an MR, and they can wait till tomorrow or longer, but not abscess. If you think the patient has a cerebral abscess, that needs to be drained because they might have come in here with a headache and a seizure, and by tomorrow they'll be dead. And you need to get an MR soon. Try and get supportive evidence, but not all patients will have fever, not all patients will have raised inflammatory markers. So let's look at an abscess, just to show you that on CT it can be hard to look different to a metastasis or a high grade. We have a peripherally enhancing lesion, we have vasogenic edema. Often the amount of vasogenic edema spreading around the abscess is much more than you'd expect from metastases or primaries because it's such an inflammatory lesion, but that's not terribly reliable, mostly because some abscesses are not terribly inflammatory if they're from, say, TB, and some metastases are very inflammatory, so there's a lot of overlap. What you want to do is get an MRI. An MRI will usually be able to give the answer 95+% of the time. And the key feature, the one thing from MR that you need to remember from today, is that abscesses show very pronounced restricted diffusion on diffusion-weighted imaging. So the centre of the abscess, not the periphery, but the centre of the abscess is very bright on DWI. Some subacute strokes, some hemorrhages in tumours will also do this. So it's not 100%, but it's very good. And more importantly, if you think it's an abscess clinically and it looks like this, you are happy to be wrong when they drain this in a couple of hours in theatre, but you have to call it an abscess. And if we look at contrast enhancement, again, we have this peripheral contrast enhancing. You can do spectroscopy and other bunch of stuff to try and increase your certainty. But at the end of the day, diffusion is the most important feature. And not all abscesses happen supratentorially. This poor guy got a cerebellar abscess. So again, peripherally hyperdense enhancing lesion in the cerebellar hemisphere. Again, lots of positive mass effect. They're facing that prepontine cistern. And in this case, when you have an abscess that's near the skull somewhere, either frontal lobes inferiorly, inferior temporal lobe, or in this case posterior fossa, look at the skull base. That'll give you a great clue of where the infection came from. It can be hematogenous, but it's often direct extension from sinus disease. And here we have mastoiditis in this chap that's extended through cortical vein and into the cerebellum and caused a massive abscess. So, in the interest of trying to draw your attention to the really important ones, these are the top threes. So we're going to start. Cerebellar mass. In an adult, especially over 50, the most common cerebellar mass, even if it's completely solitary, isolated, is a metastasis. Primary brain tumours, GBM, are really uncommon in the cerebellum. Orders of magnitude less common. So cerebellar metastasis is by far the most likely. In a younger adult, 40s, say, a hemangioblastoma is the most common. Can look very similar. Tends to have really big flow voids, like big vessels feeding it. It's a very vascular lesion. Can be part of von Hippel-Lindau syndrome. Can present with hemorrhage. And in a child, pilocytic astrocytoma, low-grade glioma. These two, if you resect them, patients well, usually complete cure. Extraaxial mass, very common. Okay? Now you have to remember all three of these are really important. Meningioma, and meningioma. By far the most common extraaxial lesion, regardless of what it looks like in the supratentorial region, is going to be a meningioma. This is your typical little lump with a dural tail up against the cortex. They can be massive, they can have edema, they can invade brain, they can be heterogeneous. They don't even have to touch the skull, they can be just on the falx. So if you convince yourself that something's extraaxial, meningioma has to be at the top of your list. And the ways to try and work out whether something is intra or extraaxial, often it's really easy, like here. There's CSF around it, the brain's pushed away from it and it's touching bone. When you have a very big lesion, it can be tricky. You need help with these, and we sometimes get these wrong as well. But if you see vessels trapped between the mass and the brain, then you know that this has started outside of that subarachnoid space and pushed. If you can see cortex all the way around, clearly that it's extraaxial, but usually you won't because it's so thinned and edematous that you won't be able to spot it. MRI is very helpful. Masses involving the corpus callosum. Corpus callosum is a very tight bundle of white matter fibres and it's very resistant to most pathology. So if you see something that's crossing, it really narrows the differential a lot. The most common by far is a high-grade glioma, or low-grade as well, but typically high-grade glioma. Typically what we call a butterfly glioma because of this shape, nothing pleasant about it. It's such a good sign, corpus callosal involvement, that if you see a patient like this that has 3 lesions that individually all look like metastases, even if they weren't all in a nice row like this along the white matter fibres that are crossing, you could be quite confident that this was a GBM and not metastases. And in this case, because they're all aligned in the direction that you'd expect white matter fibres to cross from one hemisphere to another, and therefore the direction along which you expect tumour to spread, you can be almost certain that this won't be a metastasis. So there's no point going to do a CT, chest, abdo, pelvis and waste your time looking for a primary that's not going to exist. They just need a biopsy and then move on to treatment. The other lesion that has a predilection for crossing the corpus callosum is lymphoma. Can look very similar to GBM, but usually more homogeneous, typically hyperdense because it's lots of tiny blue cells packed together. So there's a lot of cellular material. Does enhance usually vividly and quite homogeneously, won't have the necrosis that GBM will unless the patient's immunocompromised. HIV, AIDS or other immunosuppression can cause lymphoma to be centrally non-enhancing. And demyelination. Corpus callosum is white matter, so demyelination can extend across. It's uncommon for it to be centred on the corpus callosum. Here we've got a region of tumour-factive demyelination extending into. These can be very difficult to distinguish from low-grade gliomas or high-grade gliomas depending on their look. The other region that I think is worth keeping a short list of possibilities for is the cerebellopontine angle. There's really three main lesions that make up the bulk of tumours or lesions that you'll see here. The first one is an acoustic schwannoma. Typically they are hard lumps that enhance, but as they get bigger, they commonly, in fact almost always, develop some kind of cystic component. And sometimes they can be mostly cystic, so that they appear low density on CT. Giving contrast will usually show enhancement around the periphery or solidly, but the key is to look at the internal acoustic meatus. MR is much better at this, and they will need an MR before surgery, and you'll see the tumour enhancing and extending into the meatus. But on CT, what you can appreciate, because these are slow-growing tumours, is again bony remodelling. Compare it to the other side, where we have this sharp-ish corner to the posterior margin of the acoustic canal, and this sort of width. Here it's trumpeted, and this has been eroded out. Typically, sensorineural hearing loss will be how they present. Meningioma, also common, usually solid, does not have cystic components, usually not centred exactly on the internal acoustic meatus, usually does not widen the bone. If anything, it causes hyperostosis with thickening of the bone. And epidermoid cyst. Now these two look very similar. Epidermoid cyst in older scanners, and even in some times on modern scanners, can be hard to see on CT because they're almost CSF intensity. They're just desquamated squamous epithelium. On MR, it's DWI is again your friend. They vividly demonstrate high signal on DWI. Nothing else will really do that in this differential, so you can make that diagnosis easily. Now, one cautionary tale, because you always have to have one horrible story just to understand the reason why all of this is important, and why it's important sometimes without the ability to get radiology opinion, is this 20-year-old guy presented 3 times to a hospital in this country some time ago, not my hospital. Each time presented to the emergency department with headaches that were bad enough for him to turn up. Each time sent home with diagnosis of migraine, didn't have a CT. Now, it's really easy for all of us to sit here and think, how could you do that? The reality is it's incredibly hard, I'm sure, to try and filter out different people. Unfortunately, this guy went home and arrested at home, and his mum did CPR on him for a while and eventually came back to hospital and had this scan. And in this case, the fact that this was interpreted as being a pontine hemorrhage didn't matter, and we'll see why. But this was interpreted in the emergency department before a radiologist could see it, not our hospital again, as a pontine hemorrhage. And no one, if you've had CPR for a couple of hours and you've got a pontine hemorrhage, you'll die of being cast. No one really rushed to do anything to transfer him, but they transferred him anyway for an opinion. Of course, the pons is over here, so it's not a pontine hemorrhage. This is located at the foramen of Monro, and it's a hyperdense, very rounded structure. This is typical appearance of a colloid cyst. It's a little lesion that you might not have heard of before. It's not terribly uncommon. Most of them are a few millimetres in size and don't do anything except worry you once you see it. Occasionally they obstruct the ventricles and probably also obstruct the draining veins. And you get acute hydrocephalus and you drop dead. So any colloid cyst over 5, 6, 7, 8 millimetres, depends on the surgeon, depends on the patient, depends on how you feel on that day, needs to be considered for surgery. And you need to have a low index of suspicion if someone represents repeatedly with something. CTs are easy to get, and on modern scanners, the radiation dose is not that high. We still shouldn't be scanning everyone, and we should certainly think hard about scanning children, but you don't want to miss something preventable. The reason this wasn't a terrible mistake to think that it was pontine and not rush was that by the time the patient came, they already had no supply to their brain. Here we have a CTA, and you can see extracranial circulation has contrast in it, and there's nothing intracranially. You can come down, there's nothing in the carotids, down to the ophthalmic arteries, which are still flowing because they're extracranial. So the intracranial pressure is high enough to stop systolic blood flow into the brain. So you know that their ICP is going to be above 150 millimetres or something like that. So this patient was essentially brain dead at the time of this study. They had CTA is not sufficient to call brain death for the purposes of organ donation. You can do catheter angiography, or you can do nuclear medicine, or clinically, depending on certain criteria. Here they had a brain scan, nuclear medicine, showing no uptake, so no blood flow to the brain at all. So, having been disappointed 4 times in a row since 1983, I can't help but be a little bit excited about a new Star Wars on the horizon. We want to be like Gold 5 here and just stay on target for another couple of talks.